nurse who focuses on this particular group of patients. She helped me put the slide deck together mainly because I haven't actually taken care of a vasospasm patient in probably over a decade back in Chicago. But Beth works midnights tonight. She actually works midnights tonight, and she worked last night, so that's why she's not here today. So thank you, Beth, for helping me. So just to start off, really basic here, guys. I know there's a lot of folks in the room that don't take care of this group of patients either, but what we're going to focus on today is vasospasm in a patient with an aneurysm rupture. So what I first wanted to call out was just a little bit of A&P. So we're focused on that tunica media area. Basically, that's the smooth muscle of the artery, and that's the focus that we want to have with our medications and our treatments to calm that portion down so that it stops contracting and causing vasospasm and decreased blood flow. So this is kind of just the anatomy of the vessel and really what our focus is going to be on in the care of these patients. Okay. Generally, vasospasm happens due to a subarachnoid hemorrhage. And why do we have a subarachnoid hemorrhage? Number one reason is typically because we have an aneurysm that ruptures and bleeds in between the brain and the membranous space, okay? So in a vasospasm situation, what we see is a tightening of a vessel. And if you can imagine a vessel, an artery specifically clamping down on itself, it will starve a particular area of the brain of oxygenated blood. Okay, so no blood flow equals what? It equals stroke and or other issues. So that's really what we want to make sure that we don't see happen in these patients with vasospasm, is that restriction of blood flow and getting oxygen up to the brain. And then typically 50-90% of individuals with aneurysm ruptures do get some degree of vasospasm, maybe not as severe as causing stroke, but you will see some clamping down of those vessels after the rupture of that aneurysm happens, okay? Looking at imaging, our next speaker is actually going to be talking about TCDs. They're going to do my TCDs, which I'm a little concerned about because I've had a lot of coffee. But when I was a young baby nurse, this was the picture that a lot of our teachers showed us and a lot of our educators showed us, was the rubber chicken analogy. And basically, when you're looking at imaging of a brain that had a subarachnoid hemorrhage, we refer to this as the rubber chicken effect. You guys can kind of see that on that first image. I think this is a pointer here, that it kind of looks like
it's already lecture. Yeah, if you're kidding, then it's a little more complicated. Luckily, this was already started. Thank you. Yeah, absolutely.
Wait, Wood River, can you mute your mic, please? Thank you. So the rubber chicken effect in Chicago, I was told it was called the Death Star effect, which seems so much more morbid and not as fun as the chicken. But basically, this is what subarachnoid looks like, subarachnoid blood on an image versus a normal head CT. Okay, so this is what we're looking for when we get that very acute, fast imaging, whether it's in the ER or on the inpatient side. Okay, so here at St. Luke's and probably other institutions, we use different scoring and classifications to grade these on severity. The most common one here is at the top. So for nursing here in the room, here at St. Luke's, you're going to see these Hunt-Hess classifications, which basically looks at clinical severity. Higher grades, obviously worse outcomes, higher mortality, but you're going to see those patients in a very poor neurological state, okay? So that's what you're going to see on your charts here at St. Luke's, and you might even see a little bit of this modified Fisher scale. And with the modified Fisher scale, we're basically looking at how much blood, what location, and based on those two things together, will give you some kind of indication of your degree of risk of vasospasm and how severe it's going to be. Okay, so those are the two things that you're going to see here. So this is just an example of what your Hunt-Hess looks like. Just gives you that idea of 0, basically nothing, all the way down to 5, which is basically coma, probably death, cerebral posturing, so just really bad neurological symptoms. Sometimes it's combined with that WFNS scale, and you can see the GCS is extremely low. So this patient is not doing good at all if they're even going to survive the situation. Okay, so again, Hunt-Hess is typically what we see. And then this is what the Fisher, modified Fisher will look like. Basically, it has associated percentages with it depending on grade and severity of bleed and where that bleed is located. And I think my highest is the 40% down in the left-hand corner, and you can see all the blood that's on that scan that really just is not a beautiful scan at all. So highest risk of vasospasm in that patient. Okay? So just an idea of what our scales look like. So pre-interventional care and monitoring for these patients, so from a nursing aspect, where those patients in ICU, ER, or even on 90s here in Boise, we don't keep these patients necessarily in Meridian because they are going to need some kind of advanced care, and all that's gonna happen here on our Boise campus, okay? So neurological, you're gonna see these patients with new neurological symptoms, maybe not something they came in with, but something new that they've developed since vasospasm has started, and or just worsening of those initial initial exam that you saw, okay? Seizures in up to 28% of these patients, so we'll definitely be watching for that, and it could be any degree of seizure activity. Some subarachnoid hemorrhages due to aneurysm rupture will clot themselves off, but then they can rebleed again. So if they do clot off, they have a high risk of rebleeding. We still need to handle and take care of those patients appropriately because of that risk of rebleed. For nursing, we really want to make sure normotension, 100 systolic blood pressure, 100 to 140. And you are going to see blood pressure meds. Obviously, you're going to see labetalol and nicardipines and things like that on your order sets. So just pay attention to those, okay? And you're going to be doing frequent vital signs and neurochecks on these patients. This is a really great example of this picture to the left here is what you can see. You can barely see this vessel right here. There's arrows. Thank God there's arrows. So there's a smaller vessel here. This is basically a vessel in vasospasm, and then you can see to the right when the vasospasm calms down, that vessel looks bigger and more beautiful, more blood flow. So you can kind of see what the difference might be between a patient in vasospasm and not in vasospasm there. But really what we're looking for is vasospasm in that time frame of 4 to 14 days. That hasn't changed much since I was a baby nurse back east, but it can happen earlier or it can happen later in this patient's stay. It just really depends on location and how much blood is in that subarachnoid space. Okay, again, looking for new focal weakness and any other changes in the patient's LOC or confusion. You will occasionally see this delayed ischemic effect, and basically that just means that we've clamped down that vessel, and obviously we're not getting oxygenated blood out to the brain in those specific areas, okay? 50% of patients with subarachnoid hemorrhage, again, we saw this on the previous slides, like 50 to 80%. I think after talking to Dr. Pearl in the hallway, it might be even just a little bit lower than that here at St. Luke's. It just depends on early treatment, how effective our treatment is, and what our treatments are in those patients in those situations, okay? And yes, it is an emergency, so we move quickly on this. Some things that we can do from a nursing standpoint, vasospasm treatment, again, from St. Luke's standpoint, this is all gonna be an order set. I know that we have some people here that are not at the St. Luke's health system, but check your order sets and see if you have them. But basically we're looking at something called nimodipine. This is a calcium channel blocker. It does work on the smooth tissue of the vessel. We don't exactly know how it helps with vasospasm, but it does have some effect in that situation. So one of the takeaways with nimodipine today is that this is 60 milligrams. It is a pretty heavy dose. And in some patients, it will actually cause hypotension. So we can do split dosing. Instead of giving it every 4 hours, we can actually give it every 2 hours. So for the nurses in the room that take care of these patients, don't just hold the med and not give the med, split the med out, okay? Ask the docs to change your order a little bit. IV fluids and other vasopressors can also be used to increase blood pressure. The reason for the increased blood pressure is you don't want to allow that vessel to spasm. So if you push the extra blood flow up through the brain, obviously it's going to help keep that vessel open, right? So we definitely want to decrease risk of vasospasm by increasing the blood pressure. Maintaining euvolemia or high euvolemia. It used to be that we did something called Triple H where we would really give them fluid, we put in swans and do all these really fun things that I think nurses were terrified of back in the day. Wedging a swan is not a fun time, don't love it, would prefer to never do that again. But basically now we just kind of look at fluid and we try to keep their blood pressures up, we keep them on the high end of euvolemia, okay? So instead of pushing all that fluid and worrying about pulmonary edema and other things, we just stay a little bit higher than normal, okay? The biggest electrolyte we want to worry about is sodium. We want to keep that as normal as possible, 135 to 145, and there are some challenges that we see in this patient population, which we'll talk about very, very shortly. And then Dr. Pearl is here, and he's going to talk about some procedural stuff that we can do to help treat these patients, so I'll leave that for him. Some complications you might see post-intervention, hyperglycemia. Again, we want our sugars normal. For stroke, we just implemented the FAST protocol. We're watching those blood sugars very closely within the first 72 hours. It's gonna be no different for this population. So just watch your blood sugars, make sure you have a sliding scale in treatment for those whether they do or do not have a diagnosis of diabetes, okay? We just make sure we're watching that. Hyponatremia, so we're gonna talk about symptomatic, or SIADH and cerebral salt wasting, which is your CSW there. But essentially these patients will lose sodium at some point, and so we just need to make sure that we're not dipping low enough to cause seizures and other issues due to the excessive diuresis that's gonna happen. So just some challenges we might see. So we're gonna watch labs closely. And I just wanted to include, I don't know about you guys, but when I have to review SIADH, DI, and cerebral salt wasting, I literally feel like my brain can't handle all that, so I need to see it. So this is just a really good chart, and I can share my slide deck with anybody who wants it, but essentially it's just a good chart to show you the difference between the two. The biggest difference being that cerebral salt wasting is gonna have a true extracellular volume depletion, okay? So true volume depletion and lower sodium, okay? That's it for me. I'm gonna pass this over quickly to Colton, who's gonna scan my brain, I guess.
All right.
See how it goes.
Yeah, Colton Wilson is a registered vascular technologist with peripheral vascular lab at St. Louis. He earned his degree in vascular technology in 2018 after training at renowned regional medical center in Reno, Nevada, and he is recently earned the NVS, Neurovascular Specialist credential, in February 2024, which I'm very pleased, from the American Society of Neuroscience. Colton, thank you for doing this, because not many RVTs are keen on getting additional degrees, but you're a very good exception. Thank you.
There's a little thing on the top.
How about now? Now? That's better. Good morning, everybody. My name is Colton Wilson, and as mentioned, I am a registered vascular technologist in the peripheral vascular lab here at St. Luke's. Fun fact before I get started, Dr. Alexandrov's names were on most of my textbooks in school. So right now, I feel like I'm trying to tell Gordon Ramsay how to cook a chicken, and I'm terrified. So please, easy on me. And Shannon, hey, also love me some notes. All right, so my goal today is to offer up a sonographer's perspective on the diagnosis of the dynamic disease process known as vasospasm. So, as mentioned, I recently obtained my certification from the American Society of Neuroimaging to get my neurovascular specialist degree, because the idea of sitting down and going over case study in cerebral vascular disease genuinely sounds fun to me. Also to say that I swear I know what I'm talking about, mostly. So, as Shannon discussed, vasospasm is the spastic vasoconstriction of the cerebral arteries that may occur when blood leaks into the subarachnoid space of the brain. This can be caused by a variety of different mechanisms, ruptured brain aneurysm, of course, arterial venous malformations, brain trauma, and other possible causes. And the biggest concern is that this reduction in arterial caliber, arterial diameter, can lead to eventual delayed cerebral ischemia. In terms of incidence, as Shannon had mentioned, vasospasm is not guaranteed in all subarachnoid hemorrhage patients, but if it is going to occur, it's typically going to be between days 4 and 14 from that initial hemorrhage onset. Diagnosis-wise, the gold standard is digital subtraction angiography, with transcranial Doppler serving as an effective monitoring supplement that is performed for 14 days, typically from the initial onset of hemorrhage. Now, the human body has a built-in physiological response known as autoregulation that Dr. Grams had touched on earlier. And essentially, it is the body's attempt to maintain blood volume to a target organ in spite of a reduction in arterial diameter. And where's the pretty green light? Hey, there we go. So, I can't really see the ball on screen. That one there? There it is. So, in the human body, as the vessel diameter narrows, we will see an increase in blood flow velocity to attempt to maintain that blood volume to the target organ. Unfortunately, once we hit a certain degree of narrowing, the body's ability to maintain that blood volume is impaired. And you can see right around the 70% diameter reduction range, this black line here represents cerebral blood flow. That blood flow is going to decrease past that 70% reduction in diameter just because the body cannot maintain that volume of flow through such a narrow vessel. And this is the primary risk when it comes to vasospasm. This is the primary concern with vasospasm. So in terms of diagnosis, as we mentioned, the gold standard is digital subtraction angiography. It is the gold standard because it directly visualizes vessel narrowing in the circle of Willis. That being said, it does have its own inherent set of drawbacks. It is invasive. Of course, there's the contrast and irradiation considerations, as well as the fact that with any invasive procedure, there are the possibility of negative side effects. In terms of transcranial Doppler's role in cerebral vasospasm, we actually do not visualize the arteries directly. We monitor the velocities moving through the circle of Willis. TCD is non-invasive, no needles required. It can be easily performed and repeated at bedside as necessary without much limitations. The only limitations in terms of this science itself is that TCD, transcranial Doppler, is very tech dependent. Two techs scanning the exact same patient may not be able to produce the exact same results every single time. Additionally, certain patients of certain racial demographics, as well as those of an advanced age, are more predisposed to hyperostosis, thickening of the temporal bones, which is our main window into the circle of Willis. As a result, ultrasound beam can sometimes not penetrate through that temporal bone. And lastly, in terms of assessing the distal vessels of the circle of Willis, or the smaller vessels, such as the communicating arteries, both the anterior and the posterior communicating arteries, TCD is less reliable in that particular regard. Now, using ultrasound, we evaluate the following arteries in the circle of Willis. We have several sets of what we call windows that we use to evaluate the flow in the circle of Willis. The probably the most important one is the temporal window, which is through the temporal bone. Most adults have a soft spot slightly anterior from the top of their ear, which we use as a landmark to assess where their transtemporal window is. Through that window, we are able to assess the middle, anterior, and posterior cerebral arteries, as well as the terminus of the internal carotid artery. Now, through the transforaminal window, or the suboccipital window, you are able to evaluate both the vertebral and basilar arteries, which feeds into the posterior circulation for the occipitus of the brain. And lastly, the orbital window, through which we evaluate the ophthalmic artery and the carotid siphon. As Dr. Grant had alluded to, the ophthalmic artery is a very common collateral pathway in the event of an acute ICA occlusion, where the brain will repurpose the blood that's being sent to the eye and actually pull blood from the eye into the ischemic part of the brain. So on day one, post-vasospasm, our TCD will include an assessment of the ophthalmic artery as well as the carotid siphon to assess to see if the flow has reversed for a possible collateral pathway process. Now, us ultrasound techs have several key pieces of consideration that we need to be mindful of to verify that we are indeed in the artery that we say that we are in. I'll kind of walk you guys through some of these right now. So, first and foremost, we have direction of flow. So, any flow that is moving towards my ultrasound probe is going to be designated with a bright red color on screen. Conversely, any blood flow moving away from the ultrasound probe is going to be designated with a blue color on screen. The depth of the artery, for example, a middle cerebral artery is typically located between 30 to 60 millimeters of depth on screen. We can see right here that we have a depth of about 49 millimeters. So given that and the fact that the flow is moving towards my probe, given the red flow, I can pretty confidently say that this is the middle cerebral artery. Mean flow velocity, again, already touched on by Dr. Grams. Could you bring me out, Dr. Grams? This is a measurement of the blood flow in a specific artery. It is a time average assessment of the velocity of red blood cells coursing through the artery at that point in time. Typically, in a normal circle of Willis, the middle cerebral artery will have the highest mean flow velocity out of the remaining vessels that we visualize. And lastly is pulsatility. So we can see here that the patient has a PI, a pulsatility index of 1.9. Pulsatility is essentially a measurement of a capillary bed's readiness to accept blood flow, its greediness. For example, in the brain, in actively digesting organs of the stomach, that is going to be a low pulsatile, low resistance flow because those organs are in constant demand of blood. Conversely, if you look at the arteries of the extremity, they have a high pulsatility, they have a high resistance because they are not constantly demanding blood by comparison. In our line of work, anything greater than a 1.3 is considered an abnormal pulsatility index. And here we have an artery with a pulsatility index of 1.9. Now, with transcranial Doppler, there are two possible causes for a increased pulsatility index. One is chronic microvessel disease, if the patient just has a significant plaque burden within those distal arterioles and the capillary bed can't dilate sufficiently to receive that excess blood flow. Or it could be possibly from extrinsic compression, from that hemorrhagic compression, actually slowly compressing the distal arterioles in that capillary bed. With transcranial Doppler, there's no significant way to differentiate between these two. So here we have another diagram of the circle of Willis. What we have as well, though, is a couple ultrasound probes to designate the windows that we use. I've also used a couple arrows that indicate the direction of blood flow. So here, let's look at the middle cerebral artery, for example. So the middle cerebral artery is marked this guy. And it is moving towards the ultrasound probe, which we designated as red on screen. And just adjacent to it, we have the anterior cerebral artery, which is moving away from the ultrasound probe, which would be moving blue on screen. Now, in some patients, their window into the circle of Willis is actually so good that you can see through the contralateral side of the circle of Willis. So in some patients, we're actually able to see the left anterior cerebral artery from the right side. Now, that left anterior is going to be moving towards the probe, which would make it nice. Yes, it would make it red. Now, we also have some other considerations in terms of mean flow velocity. The range is typically 55 plus or minus 12 centimeters per second in a normal circle of Willis. So these are all some considerations that we use to evaluate which artery we truly are in. Now, I've given you guys a lot of very dry information, but it's kind of useless without some slide demonstration for context. So, Shannon, if you want to come on up here.
Interesting.
Yeah, I just need for a capture. Yeah. So we'll do a little practice running it then.
Meridian can do TCDs, but we will not see TCD in Meridian like we see it in Boise, mainly because the aneurysm ruptures are coiled and or clipped or whatever in Boise. So maybe you might see a TCD on like a large vessel like an MCA that we're worried about, like big types of LVOs. Grams typically will work that out. Yeah, so Boise definitely. I think they typically do what, Monday through Friday every day.
We're actually transitioning to doing them on.
Right, they have little lumps in
I know. I paused it.
Not easy apparently.
It's normal.
Yes.
So why do we say it's normal? So you can see that diastole is between half and a quarter of peak systole. And that's a normal resistance to the brain. So despite her best attempts to induce whatever coffee induces, the brain is functioning normally. And it's a normal velocity range.
Yes. So there's two pieces of information that we are shown on screen as ultrasound text. The top screen is what is known as M-mode Doppler, motion mode, which sends a continuous beam downwards and reflects any motion in terms of red blood cells. So I can see here that we have a very strong band of red between the depths of 50 to 65. Given that and the mean flow velocity listed here at 67, we can safely assume this is likely the middle cerebral artery. The bottom screen is what is known as spectral Doppler. So spectral Doppler will reflect that continuous ultrasound beam back towards the probe at a specified depth, in this case right around 60 millimeters, and it will translate and decipher it into a waveform format to convey how fast the blood flow is moving through that specified artery. In this case, we have the mean flow of 67 and a pulsatility index of 0.86. Normal as heck. Yes. Shannon, you've been a great brain. Thank you very much.
Typically take until resolution?
That was a great question for a doctor.
It's a really good question. And the reason it is normally we don't discharge people from the hospital before the vasospasm resolves, and we'll touch base on this. But in fairness, when you sort of are addressing someone with vasospasm, etc., it's your obligation to sort of make sure that they get sort of the care, typically at least 14 days, but typically 21 days. But I think the second part of your question is yes, vasospasm does spontaneously resolve with time. And vasospasm is a biphasic problem. So there's an early phase, which is smooth muscle mediated. There's a late phase, which is mediated by inflammatory cells going into the muscle wall, etc. But it spontaneously resolves typically by 21 days, but sometimes it can take a little longer.
Thanks, Dr. Pearl. All right, so we wanted to add some context to what I just showed you guys on screen, and that is the criteria. So there are two primary metrics that we use in ultrasound to assess for vasospasm. That is mean flow velocity and ratios. So we have two named ratios, the Lindegaard ratio and the Sperry ratio. The Lindegaard ratio is the mean flow velocity of the middle cerebral artery divided by the mean flow velocity of the submandibular internal carotid artery. And the Sperry ratio is the mean flow velocity of the basilar artery divided by the mean flow velocity of the average between the two vertebral arteries. And that helps us distinguish between true vasospasm versus a hyperemic response. Patients post-mechanical thrombectomy will sometimes demonstrate a hyperemic response with elevated velocities. For example, if a patient is post-thrombectomy and they have a mean flow velocity of 140 in the MCA, but their ICA mean flow velocity is 70, that gives us a Lindegaard ratio of 2.0. So even though it is quote-unquote mild vasospasm per the velocity criteria, the ratio helps distinguish between true vasospasm versus a hyperemic response. And both mean flow velocities and ratios are useful in providing insight in terms of trending upwards or downwards as we do the monitoring over a 14-day period. So, case study that I thought would help add some understanding. So, 44-year-old female presented to the ER and was diagnosed with a ruptured ACOM aneurysm. She was admitted to surgical ICU status post-clipping of this aneurysm with serial TCV scored to monitor for vasospasm. Day 6 post-bleed, TCV showed mild vasospasm with a mean flow velocity of 128 and a Lindegaard ratio of 3.7. Now, her pulsatility index listed here, it's kind of hard to see, is 1.4. And remember, anything greater than 1.3 is considered abnormal per our criteria. And we move on to day 8, and some interesting things happen. So She develops a worsening headache, and TCD shows an escalation of velocities up to 156 from 128, and an increased Lindegaard ratio up to 4.4 from 3.7, suggesting worsening, now moderate vasospasm. But what's interesting though, is that the pulsatility index decreased from a 1.4 to a 0.7 in that 2-day time frame, suggesting that the patient's EVD had actually succeeded in reducing the patient's intracranial pressure. Shortly afterwards, the patient was initiated on a calcium channel blocker, verapamil, and that helped to relax the arterial wall muscles, which allowing them to widen and restore blood flow. Vasospasm and headache gradually resolved, and she was luckily discharged to subacute rehab following her hospitalization. And I just want to talk about some other applications of TCD, since I have a captive audience here. So TCD can also be used to assess for the presence of a patent foraminal valley. It can also be used to monitor for any embolic events. We will put a headset on the patient's skull and monitor both sides of the circle of Willis with ultrasound. In a PFO assessment, we will actually inject a combination of agitated saline and the patient's blood into their IV, and we will listen for signals crossing on screen. Similar with the emboli detection, we will just do so without any kind of injection for a 30-minute time frame to listen for any emboli signals that cross on screen. In sickle cell patients, okay, missing a video demonstration here. So other application is also sickle cell disease. So pediatric patients with sickle cell disease are more predisposed to pediatric stroke, and we're actually able to monitor for their risk factor. We will assess for elevated velocities on a semi-annual, sometimes annual basis, and assess for any elevated velocities, which can prompt early intervention before the onset of any kind of a pediatric stroke. So all this to say that TCD is not the gold standard, but it is helpful in allowing us to monitor on a daily basis for any significantly upward trending velocities or ratios, which can help prompt early intervention as well. This can assist any kind of clinician in stratifying high risk versus low risk patients, and it can provide a degree of reassurance when velocities are remaining stable. And it may not be the gold standard, but it's still an incredibly useful tool that can empower clinicians to intervene early and improve patient outcomes. Thank you very much.
While we are switching presentations, any questions online? While you're doing this, and I will introduce Dr. John Pearl, who is an endovascular surgeon and neuroradiologist.